Sure. Good morning. It's my pleasure today to introduce to you Dr. Mark Mahan from University of Utah, and he was supposed to actually come to our nerve lab in the spring, and when everything fell apart for COVID, we thought maybe we can just bring him in for our grand rounds today, and he will talk to us about peripheral nerve surgery for the treatment of CNS injuries, which is a very hot topic. Mark graduated from Princeton University in '98 and then did his MD in Columbia, New York between '03 and '07. Then neurosurgery residency at the Barrow in Phoenix. He did fellowship with Robert Spinner, and that's the same place I did fellowship at. I did my fellowship '08, '09. Mark was there 2013 with the same mentor, and then he went on to San Diego. I think that was with Justin Brown in 2013, and then faculty at University of Utah since 2014. You would wonder what Mark was doing between 1998 and 2003, and he was making money. He was working at Wall Street, and I had to look this up a little bit more. And when I Googled him, it turns out that 2001, I don't know how many residents are aware of that, but September 11 happened, and it turns out that this was a turning point for Mark when the Twin Towers fell, and he decided to go to med school. He was the secretary treasurer for the peripheral nerve section, which is a division from the joint section for spinal and peripheral nerve. That he was treasurer between 2016 and 2019. Now he's president-elect, and then 2022 he will be our president for 3 years. Member of a bunch of committees, and I got to know Mark through the years. Through the American Society of Peripheral Nerves, the Sunderland Society, more than 60 peer-reviewed publications, another 20 book chapters. He is a reviewer on most of the journals you will submit to: Neurosurgery, Operative Neurosurgery, World Neurosurgery, amongst others. He has lectured locally, nationally, and internationally. And this is probably the last meeting we were in at the here he is performing in Tel Aviv during our Sunderland Society, sorry, Mark, Sunderland Society meeting. All right, Mark, the floor is yours.
Oh, thank you, Amgad. That's very kind and very generous of you. I sincerely appreciate that kind introduction. Um, Hope that the slides have come over across now. And I do want to thank you all for both the invitation to give grand rounds as well as the opportunity to talk on a particular love of mine. And because this is CME activity, go over some brief disclosures that I have. We have an NIH-funded lab, and I have some consulting relationships, none of which impact the presentation today. And as a way of introducing what we're going to be talking about, I'd like to start off with, once again, thanking Dr. Hanna. I was really excited about the opportunity to come to Wisconsin for the ability to participate in the lab and to interact with you one-on-one, and unfortunately cut short, and to be there to really be part of his vision. And secondarily, because I think that there's a real moment in these grand rounds that sometimes is lost in the transition to teleconference and telemedicine. Unfortunately, we're all on our laptops. We all have the opportunity to do email, to do other activities, and I'd really like to emphasize, particularly for the residents, tune in. This is your time. Grand rounds is the one opportunity, or sometimes the opportunity, where you're allowed the opportunity to focus on something that's not directly related to patient care. And these are the opportunities for you to really see new options for you to see your career in a new light, to really have some inspiration, you are going to have an opportunity during your grand rounds to see some really fantastic speakers, to have moments where you can see some future glimpse of yourself and really have the inspiration to see what your career can go towards. And I think that's really important now more than ever, to really take that moment, take it back, spend some time, be open for that inspiration and seize it, because it is truly, if you're open for inspiration, you're going to achieve so much more in your career. So if there's anything you take away from this, it's not necessarily what I say in the upcoming minutes, but it's more about taking the opportunity to listen and to think about your future, because it's open, and that's what you do as neurosurgeons. We're here for innovation. We're here for making people's lives better. So I really want to emphasize that as far as we go. And from that, here we start. There is a difference between the peripheral nervous system from the central nervous system. And as a neurosurgeon, you're going to spend most of your time focused on a lot of aspects of the central nervous system. And today we're going to take a little bit of a change, because we do know one thing about the central nervous system, and that is that it is relatively poor and meager in its ability to heal itself. This was published by Dr. Eilis out of the UK. He's a wonderfully internationally recognized researcher in spinal cord injury. And he published this article in 2011 that clearly outlined the sad fact of that central nervous system regeneration does not occur. And although many of you may recognize there are some publications showing some limited regeneration capacity, I can think of recently in March, Chizinski's lab out of UCSD published a paper in Nature saying that there are some states of neuronal dedifferentiation. But fundamentally, we know clinically that there may be some evidence of limited CNS regeneration, but it is of doubtful neurologic significance. And through medical school and your studies as a neurosurgeon in training, you know there are many, many pathways that lead to that blockade. This is that schema showing a glial scar in the spinal cord after spinal cord injury, and it demonstrates all the different aspects, all those little cartoon characters of what things block successful reinnervation, regeneration after central nervous system injury. And they wonderful things, names like no-go and other proteins that really do limit the ability of axons to reverse scar. And what's interesting is that it's fundamentally programmed. There seem to be an innate program that says that after central nervous system injury, we don't want regeneration. There is a cascade that occurs that is anti-regenerative in some respects, that really does limit neurite extension. And there are numerous pathways that all lead to that same consequence. This schema provides for that. You see multiple different systems, multiple different signaling that all lead to that growth cone collapse, neurite retraction, and apoptosis. There are probably good reasons why the CNS does not regenerate on a long scale. And probably the good reasons are we want to preserve complex circuits. We know that the brain is full of relatively complex pathways for emotional processing, visual processing, etc. And so that if you had those pathways die off and regenerate, you might lose the underlying circuitry. Similarly, we want stability of those reinforced pathways, that when you do learn to speak, that you have established a language, a vocabulary. We want those pathways to stay stable for long periods of time. And so again, the idea of replacing those cells is not to our advantage. And lastly, for a species that's designed to live 8 decades or more, we do want to reduce the potential cancer risk in those long-lived cells. So it does make sense why there is a pathway that limits cellular regeneration within the CNS. However, the peripheral nervous system does regenerate, and oftentimes relatively impressively so. meaning that it's not uncommon. The spine surgeons here will gladly recognize there are patients that come back 3 years later who had an L5 radiculopathy, and their toe sensation comes back finally because of the immense capacity for nerves to regenerate even long distances of 3 feet or more. And the good reason why the nervous system regenerates is that nerves are located in vulnerable locations, meaning that every time you hit that so-called funny bone, right, when you hit the ulnar nerve in the retrocondylar groove and you get that shocking sensation is probably the death of a couple axons. You do that repeatedly over your life, and you'd have no hand intrinsics by the time that you were about 40. So we need nerves to regenerate. And it's relatively simple that we encase that non-regenerative central nervous system in bony canals and a bony skull versus the peripheral nervous system, which is always exposed. It is always on the limbs of the surface. And so those are subjected to trauma, as we just described, either concussive trauma or others. But they must accommodate strain and stretch. When you bend your wrist and you bend your elbow, you subject the ulnar nerve to about 22% or more strain. They have to accommodate that sort of vulnerability. So we do know that nerves, in contrast to the central nervous system, nerves must regenerate because we have to have that continued function. And likewise, we have that programming to heal. This is a cartoon from Tessa Gordon's work that shows the regenerative capacity after nerve injury. The distal axon retracts a little bit, and then the neuron expresses numerous genes known as regeneration-associated genes, or RAGs, immediately after injury to start the process of neurite extension and reestablishing connection. On the other hand, the distal nerve, the axon, undergoes Wallerian degeneration, which is programmed into the neuron itself. It's an automatic program we've learned over time, and that the Schwann cells and other sustentacular cells of the nerve start to release neurotrophic factors that basically the come hither signals that bring the nerve back to its target. And this occurs immediately, and it's generally very successful. This is out of Sain's lab at Harvard, where they looked at a transgenic animal where the neuron expresses a green fluorescent protein, and they then stained the muscle with alpha-bungrotoxin in red. And you can see after crush injury, the before is on the left, the after is on the right, low magnification on the top, high magnification on the bottom, that the axon regenerates with fidelity back to its original targets. You can see in that high-powered magnification that the axon will skip other motor end plates to preferentially reinnervate the ones it previously targeted. We know that nerves have incredible capacity for that regeneration. Not only do they go back to the original targets, but they can also innervate additional targets. And this is the phenomenon of collateral sprouting. This is important in both skin reinnervation as well as muscle reinnervation. But a lot of us as peripheral nerve surgeons spend a lot of time focusing on motor innervation. And so that's what I brought up here. Fundamental fact is that when an adjacent neuron or axon dies or is severed, the remaining neuron and axon will sprout collaterals. Said alternatively, you'll see motor unit enlargement on your EMG. These become much bigger motor units, and they can expand massively, about 5 times their territory, and we'll go into that a little bit later. But the important part here is because of this collateral sprouting, we can borrow nerves, and the remaining portion of a nerve can collaterally sprout and reinnervate the muscle. So you can borrow partial innervation and achieve a lossless transfer of some function from a motor unit to another motor unit, while maintaining innervation of the motor unit you borrowed from, meaning that you can borrow from biceps, transfer it somewhere else, and still have good biceps function. So to summarize, we really do have 2 different nervous systems. The central nervous system is really designed for a limited local recovery, meaning that when neurons do die and the dendrites are exposed, there is some local regeneration to those to cover the dendrites. But it's not massive, it's not regenerative. Whereas in the peripheral nervous system, we see long neurite extension, we see long axonal regeneration. And I think that the people that are thinking about that's going to automatically realize what the point of this talk is. Well, why don't we use the peripheral nervous system regenerative capacity to improve after central nervous system injury? And we'll talk about that in two ways. There are many ways. I'm only going to focus on two for the sake of time. We'll talk about nerve transfers for spinal cord injury, as well as treatment options for spasticity. So in spinal cord injury, as I alluded to, we're going to borrow a portion of innervation to reinnervate a deinnervated target. Oftentimes what that means is we're going to borrow some of the motor control from above the level of the injury and transfer that to the levels below the level of injury to re-achieve functional control further down on the limb, particularly for the arms. We're moving function down the arm to the hands or to the triceps. For spasticity, this is a little bit more complex story, but I think you'll understand it relatively easily. The loss of descending inhibition and motor control, as well as that unmasking of dendrites where the input is lost and there's a local recovery of input, means there are exaggerated reflexes. And so patients become relatively spastic after numerous central nervous system injuries. And so what we can do, we can trim the nerve and reduce the sensory input that causes the reflex spasticity while maintaining that efferent output, that motor output, and continued preserved motor control. So we'll go into that a little bit later, but let's talk first about spinal cord injury. This is a topic that needs no introduction to this audience. Everybody here is very familiar with spinal cord injury and the causes and the devastation that it has for individuals. And in a schema, we have simplified the idea that you have in an injured segment of the spinal cord, called the injured metamere, as well as the supralesional segment and the infralesional segment. These are just terms to help codify what we're going to talk about. But we know that in that injured segment, you have a loss of both the descending pathways as well as the alpha motor neurons in the anterior horn. So when you have a loss of those motor neurons, it's essentially kind of like a nerve loss, right? It is like a nerve injury. But in the infralesional segment, that's not the case. The system is still intact. Again, what that looks like on an MRI, you have a normal segment above the level of injury. You have a level of injury which has a loss of motor neurons. And then below that, you have an intact system. This presents two options. You can consider at the time of injury or within 6 months before the motor unit or the muscle and nerve becomes incapable of regenerative capacity, you can transfer from the section above the level of injury under cortical control to the nerve supplying a muscle that has been de-innervated. And you can do that and achieve reinnervation of the muscle and the nerve. More commonly is what we're talking about is this scenario. Because oftentimes with spinal cord injury, we give patients a fair amount of time to see how they do. And some spinal cord injuries can make massive recovery within that first 1 to 3 years, where they get substantial recovery of function back, substantial compensation, and substantial improvement. But at the same time, a spinal cord injury is a spinal cord injury. After that point in time, function oftentimes plateaus. And you can still perform this type of nerve transfer when you're going from the supralesional segment to the infralesional segment because that nerve is healthy. You are essentially doing a nerve repair at day 0. You're cutting a healthy nerve and you're repairing it with a healthy nerve. And you can get fundamentally profound reinnervation. And so when we think about spinal cord injury, these are the tasks that we want to achieve. The first is grasp. For a lot of spinal cord injury, primary focus is achieving hand function so they can perform activities of daily living, oftentimes for simple privacy's sake, like self-catheterization. Correlate of grasp is the release. Naturally, you need to have your hand open to be able to grasp objects. And then lastly is elbow extension, because the ability to achieve a meaningful elbow extension allows for more pivot and transfers. Oftentimes, for a lot of individuals, that it's also the opportunity to do a hand-powered wheelchair as opposed to a more bulky, more cumbersome, more difficult electric wheelchair. And as you see in this chart, there's a series of different types of nerve transfers where we can move functions from a level above to the level below. As you see, like a brachialis, which is essentially a C6 level nerve, to the anterior interosseous nerve, which is the same thing as a C8 nerve. Same thing for supinator branch, C6 to posterior interosseous nerve, C8. Elbow extension, axillary, C5 to triceps, C7. What these look like, there are options, there are variations, and I'll show you two. This is the idea of doing a limited dissection in the upper arm, transferring a branch of the biceps and brachialis, as you see in panel B, to part of the fascicle, the anterior interosseous nerve, or the median nerve at the arm, as you see in panel A, completing the transfer as you see in panel D. My personal preference is a little bit different. This is how I prefer to do the surgery, where you dissect out the anterior interosseous fascicle all the way from its origin back up. And the reason is that at each level of this dissection, you're separating little connections between the median nerve and the anterior interosseous fascicle. These little side connections provide reinnervation, and you want a complete deinnervation of the anterior interosseous nerve so that when you do the brachialis transfer, that you're transferring into a nerve that is hungry, not one that's going to be competed by other sources distal to your transfer. This is what it looks like in lower magnification. Release. So the posterior interosseous nerve is the nerve that controls our hand open, thumb open function. And as mentioned, that's a C8 type of nerve that primarily receives most of its innervation from the C8 level, and that the supinator is a C6. It's just like biceps. Biceps is a primary supinator of your forearm. The supinator is a weaker one. But what's really nice is that the C6 nerve is in close opposition to the posterior interosseous nerve. And you can see that it's a relatively short transfer, and it's relatively close to the muscles, and you can achieve pretty impressive hand opening from this tiny little transfer. And then lastly, an axillary to triceps. You probably worked with Dr. Hana and you've done repair of the axillary nerve for brachial plexus injuries where you're taking a bit of triceps and putting it to the axillary nerve to get better deltoid function. This is the reverse, borrowing a little bit of axillary nerve and transferring that into the triceps. Works the same and has the same consequences for successful reinnervation. And now we're at the point of doing this on a multi-centered trial basis. The Department of Defense has just this year, 2020, has agreed to do a trial and is sponsoring it. And it's hopefully this trial will establish this as a very essential part of care for our spinal cord injury patients. And what this trial really looks at is a series of those same sets of transfers for achieving better wrist, hand, elbow function. Switching gears a little bit, let's talk a little bit about spasticity. Spasticity is relatively complex. And to dumb it down, to simplify it as best as I can, is really, what we see is that after a central nervous system injury, many of the conditions you see here, the most common ischemic stroke, is that there is a loss of descending inhibition from the brain. Oftentimes, it is loss of that activation that we see with the rubrospinal tract that leads to excessive motor patterns. Okay, again, audience, you know this intuitively, that the patterns of movement that we achieve in our arm is not directed from the motor cortex, but it's really the motor cortex sending a signal down to the local pattern generators in the spinal cord. The spinal cord itself is the program that we use to achieve programmed movements. And so when we have that loss of cortical input, we see these patterned positions after stroke. Oftentimes, it's the internally rotated adducted shoulder, flexed elbow, pronated forearm, flexed wrist, flexed fingers, and a clenched fist, which everyone in this audience recognizes immediately, not only from seeing patients with stroke, but from decorticate posturing. It's the same problem. The lower extremity is very similar, often with adduction, flexion, and then particularly equina varus of the foot. Equina varus is that plantar flex foot that's also internally rotated by posterior tibialis, and it creates an unstable foot for walking. So somebody who could walk has the problem of having the base of their stability is being disrupted by this equina varus positioning. Now, we tend, rehab, neurology, when I say we, the general field, tends to prefer to do these non-surgical treatment options, like physical therapy, muscle relaxants, or oral, all sedating, as well as chemodenervation like botulinum toxin. The challenge is that you have a static and permanent disorder with regard to spasticity, and you're using temporary agents. And the unfortunate problem with that is that oftentimes, because it is a persistent condition, after about 3 years, you get progressive contracture because you've just been using temporary treatments. For spasticity, there's a surgical rubric that most people are familiar with. The first is that for generalized spasticity, you're going to use a continuous intrathecal baclofen pump. But we do know that sometimes, and as everyone in this audience has witnessed, that still leads to progressive contracture. Those with spastic diplegia, particularly the cerebral palsy patients, lumbar dorsal rhizotomies work well, but they are relatively non-selective for motor pathways. You're sectioning dorsal rootlets. That includes cutaneous afferents as well as muscle afferents. For focal spasticity, my preference is peripheral neurosurgery. And what that means is after the failure of conservative treatments, which we generally know is going to occur, you can consider things like tendon lengthening and peripheral neurotomies. Unfortunately, tendon surgery really doesn't work because it doesn't treat the primary pathology. The spasticity remains. This is a publication out of our group, our hand group, that basically has found that they got late deformities when they did a spastic muscle transfer. The unfortunate thing is the majority of the patients were excluded from the analysis, so you're left with that bottom conclusion. You have to assume that the incidence for recurrence of spasticity and deformity is somewhere between 50 to 100%. It's not a great option. For peripheral nerve surgery, we know what the good surgical candidates look like. They tend to be those that are healthy enough to undergo surgery and a level of benefit that would improve them. But these are relatively modest goals. This is something like you're trying to decrease their pain or discomfort associated with that spasticity. Hygiene, for example, somebody who has a clenched fist, over time, that fist will smell like fish. It's really quite hard for a lot of individuals to maintain hygiene. And improve cosmetic appearance. I can give you the example of one very kind lady who I would not consider vain, came to me and said the reason why she wanted to treat her spasticity, and she said, because I want to stop looking like a damn cripple every day. It's that kind of level of social interaction that's important for individuals. And for those, like we talked about equina varus, that if you can get the foot in a good position, you can improve their mobility. You can improve their functional independence. Naturally, these poor surgical candidates include those that are spasticity you can't treat with peripheral neurectomies like quadriplegic spasticity or dystonia, which is really a preferred positioning. This tends to be the pathology that occurs after deep brain hemorrhages, so nuclear or gray matter type hemorrhages deeply in the brain, then like the head of the caudate, where it's not spasticity like I've described, where it's an exaggerated reflex, but it's really a pattern of movement. And I've failed 2 patients that I know of that where we've had recurrence of their spasticity after repeat surgery, I, at the time of the second surgery, thought there was so little left of the nerve that I would be surprised they even got any recovery. And yet they would come back 3 months later and have profound elbow flexion, and showing me that it's really a preferred position, that anytime you leave any innervation, they're still going to be able to bend their arm. This is what the surgery looks like. I apologize for the video is a little bit spastic. But this is a surgical procedure for treating a branch to the gastroc. The tibial nerve is the big nerve up in the upper left, and you can see as trimming this branch, it's really quite clear that it's a monofascicle. It's just one bit of fascicle. And so what I'm going to do is here is with the 11 blade, trim into the perineurium, the outer layer of the fascicle, and start to splay the nerve fibers themselves a little bit more clearly. I have selected about 50% of the nerve here to trim. And I'm going to cut out a window here in just a second to take that and section out that nerve so we don't have regeneration. There's profound contraction to distal stimulation and no meaningful contraction to proximal stimulation. The fun thing is that you don't really create a palsy with that. Even though you saw very little distal contraction with electrical stimulation, you don't have much palsy after the surgery. And the reason why is that the goal of the surgery is you're trying to reduce the afferent input, not the efferent output, right? So in that motor branch, only about 25 to 50% of the motor branch is motor signals from the spinal cord. What we're trying to do is reduce the amount of information from the muscle spindles that mediate those stretch reflexes. And this is that schema, right? That you can think of it two different types of fibers. Sensory input that's going to give you proprioceptive sense, right? These are the muscle spindles and spray end organs that tell us two things: the state of the force of contraction and the length of the contraction. And that's how we achieve proprioceptive sense of our limbs. Meaning that when we know how forceful we're contracting and how much length our muscle is, we know where our limb is in space with our eyes closed. And that's the reason why we have so much more input. The motor nerve itself, again, is way more input than actual output to the muscle. So when you deinnervate and partially section the nerve, you're reducing that afferent input. And as we talked about before, the motor output still remains and will collaterally sprout. This is well described. This is a sample of muscle harvested from patients after surgery. The first is the control population, where you see an ATPA stain, which shows the typical mosaic pattern of motor units. And on the left, and that's where you see type 1 or slowly fatiguing fibers in black and fast fatiguing fibers in white. And you have that typical mosaic pattern of motor units. Now, after selective deinnervation, you see the opposite. You see that group fiber typing, where all the motor unit, all the muscle cells in that sarcomeres have a typical phenotype of either being slow or fast fatiguing. And what we do know is that those motor units can enlarge to approximately 5 times their original size. Said alternatively, if you can increase your motor unit by 5 times, you can section to about 80% of the nerve, leaving only 20% behind, and achieve complete reinnervation of that muscle. Question is how to do it. And this is the hard part. As you saw in that video, I only sectioned about 50% of the nerve because that was somebody who had good motor control. And I didn't want to lose too much of their motor control because, as I said, part of the afference is proprioception. So you want to, for somebody who is high functioning, that has some good motor control, you don't want to section too much because you would like to leave proprioceptive sense. But at the same time, you do want to section enough that can reduce some of that reflex arc. And as mentioned, that sensory information cannot get back to the muscle. once you've sectioned out that 1 centimeter segment like you saw me do, it doesn't reinnervate. You don't reinnervate muscle spindles. You don't get that same information back. The nice thing also is you also reduce pain fibers that come from the muscle. And so a lot of my patients describe less pain from their spasticity, either as a reduction of their spasticity or a reduction of the pain fibers to the muscle. This chart basically summarizes anything that has that movement that we described before of stereotype patterning after stroke. There is naturally a nerve approach that we can have to achieve functional reduction. Same thing for the upper limb, but it's relatively a little bit more straightforward. There's oftentimes only 3 movements that we're working on in the upper limb. This is a patient, a spinal cord injury, who's trying to bend their arm up to their face. And you can see both on the grimace on his face, how difficult it is and how hard it is for him to try to get bend his elbow because of tricep spasticity. This is the surgery that's performed. This is an anterior approach to the radial nerve. So this is through the axilla. And the reason why is you have to go through the anterior approach to get to the long head, the innervation to the long head of the triceps, which is much more challenging from a posterior approach. So I prefer an anterior approach and identifying all the different tiny branches to the triceps from the front. And this is what the recovery looks like, where you're going to see when he bends his elbow up, you see much more fluid movement, a much easier movement. Not as good as you and I. We can touch our face much more easily, but a profound improvement in his tricep spasticity. So what we see with this type of surgery is we get better positioning for people who have contractures or tightness. You have greater mobility for a lot of individuals, meaning that, for example, those that with difficulties with their foot control, they're able to move more independently. They're going to have increased use of sometimes of their limbs because they're no longer bothered by their spasticity and have, in some cases, better motor control. They'll have less medication side effects because of the decreased use of sedating medication. And so I'm going to present real quickly in the time that's remaining a little bit of our outcomes from this surgery. We looked back at the past 4 years of what we've done for spasticity surgery. And we focused on our outcomes. And I want to make a particular emphasis. This is not my evaluation. This is an independent physical therapist who said what the preoperative spasticity score was versus the postoperative spasticity scores. Because I really do not like surgical series that have the surgeon's rating of their success. Because it's like looking in a mirror and saying how good you look that morning, right? We tend to be a little bit more generous on ourselves than others. And so this is an independent evaluation of tone. Secondary outcome is the patient satisfaction. And because I think that's also important too, because that's the ultimate goal. And you'll see that there's a little bit of variation between the two. This study included 38 patients, 88 procedures, because we are oftentimes doing multiple procedures on a limb. And you can see that the breakdown of causation is relatively wide, with ischemic stroke representing the most common, but all sorts of CNS injuries also included in our results. The most common treatment was elbow flexion of the upper extremity, followed by plantar flexion of the lower extremity, and some broad series of just other minor procedures. The spasticity score we used is the modified ASHWORTH score, which is the most common and most consistent inter-observer reliable score, but it's relatively poor at distinguishing grades of spasticity. Let's take a look at grade 2. The affected limb is easily moved. Grade 3, movement is very difficult. That's a pretty binary change. The other ones, the slights, grade 1 and grade 1 plus, relatively meaningless. So going from a grade 2 to grade 3 is substantial. And this is what our results look like. These are the plots of individual patients with the dots, and you can see that overall the patients are going from an average score of about 3.5 to an average score of about 1.5 or so on the modified ASHWORTH score. And you'll see we'll go into each of the individual movements, but overall these are relatively statistically significant results, even in sometimes small populations. So example, this is again a surgical image of what we're doing to achieve control of the quina varus positioning. Up at the upper top are the medial and lateral branches to the gastrocs, and on the lower right, branches to the posterior tibialis and to the soleus muscle, as well as the tibial nerve in the middle. And you can see the patients are going from an average Ashworth score of a little over 3 to an average Ashworth score of 1. Similarly, for elbow flexion, where we're treating unwanted biceps tone, this is the musculocutaneous nerve as well as the median nerve seen below, where all the 2 to 3 branches of the biceps are identified and the branch to the brachialis is identified, disassociating from the lateral interbrachial cutaneous nerve, and treat each of those tiny little branches differentially. These patients are going from on average score of nearly 4 to an average score of about 2 afterwards. Finger flexion is much more challenging as its correlate wrist flexion. And the reason being is that these are relatively, there are more muscles that are treated, they're more complex in their action. And so achieving good functional results is a little bit harder. This is a patient that had a lot of tone in his hand, obviously a lot more difficulty, but he had good control and he was pleased with his hand afterwards. These tend to be much more modest as far as improving. You see that we're not getting the same reduction in modified Ashworth score because of hand function. Same thing with wrist. Wrist is relatively complex because it's contributed by flexor carpi ulnaris, flexor carpi radialis, palmaris longus, all the finger flexors. So getting a good result at wrist flexion is relatively hard, oftentimes because patients do not have innervation or successful innervation of the wrist extensors. So it's unopposed. Yet at the same time, our modified Ashworth scores improve consistently in all the major categories that we examined. One of our physical therapists has been very diligent in looking at walking analysis. And I know this is a busy slide, but the top shows those patients that have been followed for longer durations show dramatic improvement in their 6-meter walking time as well as gait speed. Those that have been shorter, followed up, those bottom two, tend to have less substantial results. And I think that's just a function of how much time. So I present all of our results in honesty, but at the same time knowing that this is something that requires some gait retraining afterwards. Also important is the subjective report of our patients. And you can see things like this, and I highlight this again for the residents, is that some of these comments are just absolutely heartwarming. This is the stuff that makes you feel just genuinely delighted with your day. When somebody says, it changed my life. For these surgeries, this takes about an hour in the operating room. And it's not the most complex surgery you're ever going to undertake. But when you hear things like this, it's truly wonderful. So we categorized our patient responses with a LIKERT type scale, 4 being patients fully satisfied, and 1 having a worse outcome. And this is what we see with all patients basically achieving about a 3.5, with the majority having a score of being completely satisfied. Obviously, I would be a liar if I told you that everybody was perfect, everyone was delighted, and that's not the case. But what's interesting to me is that if you look at those scores broken down by the movements we previously described, everybody's pretty much the same level of happiness. Even though I've told you that I'm not as successful with the wrist and fingers as I am with the elbow flexors, patients are the same level of happiness. And that's quite, or satisfaction, I should say. And I think that's quite reassuring. And the reasons, as I said before, are relatively common. Things like elbow bending is against gravity. And so we have gravity as an adjunct to improve our outcomes. Same thing with plantar flexion. When the body weight is on the foot, there's gravity reinforcing the surgery. Whereas with the hand, there's oftentimes there's no opposition to it. And that's the reason why our results tend to be a little bit more meager. But at the same time, individuals are at the same level of satisfaction.
Mark, when do you get those assessments? What's the recovery time when you begin to see actual functional change?
You will see the decrease in spasticity immediately after surgery. So it is so somebody's tone should be obliterated after surgery.
But as far as the physical therapy to improve the gait and such, is that like 3 months later you're doing those assessments or what?
We start physical therapy immediately after surgery, meaning that those individuals should be walking out of the hospital even if they've had a lower extremity surgery. And we want them to start moving immediately and start the benefit. The problem is that their muscle strength is oftentimes much weaker, and it does take some time for some of that to regenerate. And so their maximal improvement takes about 3 to 6 months.
Okay, thank you.
This is obviously a surgery with its challenges, and I've highlighted some of them. The dystonia patients this is not a treatment for them, and we're still struggling to figure out what is the best option for those individuals. The extent of resection is an art, and as you see that there are sometimes failures, and achieving that successfully, and discussing that with your patients is particularly important. And then the idea of when do you use transfers either of tendons or nerves to try to achieve opposing force. As I mentioned, like with fingers, if somebody doesn't have finger opening, reducing the spasticity of finger closure is oftentimes a little less than satisfactory. You do make the hand a little less tight, but you don't get, as reinnervation occurs, the fingers curl a little bit back. And so trying to continue to see if we can improve that with either nerve transfers or other procedures to optimize the results. So again, this is the summary for spasticity. This is our first North American series, and it really is a powerful option for helping individuals. In conclusion, starting from where we started, the CNS is different. It's the consequences of CNS injuries is oftentimes a little bit is different. It leads to spasticity and other problems, but we can be treated because even though it has limited recovery, the peripheral nervous system has an impressive ability for regeneration. And for patients with spinal cord injury, nerve transfers can have a meaningful and impactful improvement of their quality of life, which we hope to establish as a standard of care in the upcoming future. And then lastly, that highly selective neurectomies is a simple outpatient procedure that can be done that can meaningfully improve the quality of life and functional independent capacity of individuals. With that, I sincerely thank you, and I really sincerely appreciate your time, and I hope I can answer some questions.
This is excellent, Mark. I mean, it's really thoughtful and it's thought-provoking, and that's two outstanding goals. Are there questions?
That was terrific, Mark. I have a question. How do you get started on a program like the spinal cord injury? Do you go give this kind of talk to the rehab people? Because you get them pretty chronic.
Yeah. With regard to spinal cord injury?
Yes.
Yeah, so a lot of time spent with the rehab doctors, but also time with the physical therapist. I find that the physical therapists themselves are the ones that know the patients best, and they're the ones that have the most influence with the patients. So I spend more time with our therapists than I do with our rehab doctors.
Sure.
Mark, this is excellent. This is Benny Iskandar in pediatric. The first question about spasticity. What do you think of chronic reinnervation to cause pathological recurrence of spasticity or even pain? And the second question is, there was a Chinese neurosurgeon that a few years ago started doing similar type of nerve transfers from lumbar region nerves to the bladder to try to reinnervate bladder and in spina bifida, and that failed. Well, he says it succeeded, but everybody who's tried to replicate this failed, and I think it's because in the congenital population, you actually probably never develop those motor end plates, and therefore that procedure isn't gonna work. And so, as it regards the congenital population, it seems that the next step would be doing the same kind of transfer techniques that you're using, but into prosthetics. And so, do you have any idea about the future of going from nerve root to prosthetics?
Those are wonderful. Those are all three wonderful questions, right? The idea of what do you do with congenital populations? I have treated a lot of congenital adults, some children, and they do well, but it's with much more modest goals because of the chronicity of what they've developed, and their motor patterns are different, as you well pointed out. They have learned different walking gait patterns than you and I have, and so it's much more difficult to achieve the same results. With regard to bladder, absolutely, that publication has kind of dimmed the prospects for that field. If there's work from Temple with Mary Barbie's group that they've done some canine bladder reinnervations that seem to be successful. So maybe there's some opportunities, but still quite the future's undetermined. And lastly, with regard to nerve transfers for prosthetics, it's a wonderful field, and I think that we'll get a boost from devices that continue to be developed for decoding muscle action potentials, because muscles are wonderful electrical amplifiers. They're very easy to read from surface EMG, and combining that with prosthetics, particularly for our limb amputation patients. I don't know in the congenital population, it's because again it is a co-contracted state. My experience with a lot of those individuals is that decoding their motor movements is much harder, because what we see is that there's baseline activity in all muscle groups simultaneously, and that they pair a lot of agonists, antagonists at the time of movement initiation. And so I don't know. I don't know what the results will be of that.
Chronic reinnervation with spasticity neurectomies. Any idea about long-term pathologic reinnervation?
You mean like so the surgeries that I'm performing and how that affects those individuals?
Yeah. Well, no, I mean the surgery you're performing. How about if you look at them 5 or 10 years later? Could there be reinnervation that's pathological?
Yeah, I haven't seen it yet, and that, as you rightly point out. I mean, we're not looking 10 years yet. Marc Sindhu out of France had published some results that were 10-year follow-up, and he showed some recurrences of spasticity. The problem is that he had a very mixed population, and as you know, that for example, those that have static disorders are very different from those that have progressive disorders. Mm-hmm. So treating a patient with multiple sclerosis with neurectomies, you have to consider it palliative. It's not going to be improvement because they're going to have progressive disorder. They're going to have a progressive central nervous system injury. And the same thing applies to kids. So if you're taking the children that have genetic disorders that are underlying their spasticity, you're going to have much different consequences to those that had maybe static birth injuries or gestational injuries.
Mark, I want to thank you once again. This has been extremely enlightening, and it's basic principles applied to patient care. That's what we all should be doing. It's a pleasure. Thanks again.
Thank you again. I appreciate it.
Thanks, Mark. That was terrific.
Take care now.